Okay, I think we're going to get started. I love seeing a packed room. Thanks everyone for coming. I'm going to just a quick PSA. We're going to do some questions at the end, so feel free to scan the QR code, and then we'll save about 10 to 15 minutes at the end for all questions. But let's get started. I'm very excited. So I'm just going to have everyone briefly, 20 seconds or less, introduce yourself, name and title, and we'll start with you, Dama.
Hi, everybody. Thank you. Hello.
There you go.
Hi. Awesome. Well, welcome, everybody. Thank you for being here. My name is Damayanti Dipayana, but you can call me Dama. I am the CEO and co-founder of a company called Manatee. We provide mental health services for families. I am from the Netherlands originally, and I have 3 kids. So I take the CEO and the parent lens in this topic.
Hi, everyone. My name is Alyssa Dietz. I'm a clinical psychologist by background. I'm head of clinical strategy at IESO, where we are leveraging our experience treating 750,000 hours worth of patients to create programs that serve up what people need, both digitally and with a human component as well.
Hello, everyone. Happy to be here. My name is Boaz Gaon. I'm the Chief Product Officer and founder of a company called Wisdo Health. Wisdo has taken on the mission of curing the loneliness epidemic at scale. We do that by creating digital social support networks that are sensitive to people's profiles and then baseline them against mental health, loneliness, and other mental wellness measures that get assessed on a monthly basis to make sure that the connections that we provide to people actually is moving them in the right direction, which we feel is the shortest path to curing this problem that 50% of the population in the U.S. are facing. Happy to be here.
Hello, everyone. I'm Michael Castanon. I'm the founder and CEO of Care Predictor. We focus on the science of the therapeutic alliance, the fundamental driver of positive outcomes. And so we leverage that science using technology and AI to really optimize clinical outcomes and organizational performance.
Hi, I'm Greg Harris. I'm the Senior Medical Director for Mental Health at Blue Cross Blue Shield of Massachusetts, and I'm a psychiatrist, and I still have clinical practice, so I'm a practicing psychiatrist as well. Thanks for having me.
Thank you. I love the wide variety of expertise. So today we're talking about striking the right balance between data-driven tech and human connection. But before we start talking about striking the right balance, I want to talk about why doing so today is so critical. And I think a lot of people would argue that the current system is broken. So I sort of want to start by centering us, and I'm going to start with Dama and just go down the line briefly and say, what is one of the most critical perils of the current behavioral health system that needs fixing? I know that's a hefty one to start with, but here we go, and then we'll move on from that. Just one of the most top of mind things that you think we're falling short today.
Wow. I think for me, we've talked a lot about how do you provide access to care. Kind of taking the lens also where technology comes into play. What the hardest part is, how do you have really high quality, exceptional care? And I think that's ultimately where we fall short, where it's really hard to monitor, to evaluate. And technology oftentimes hinders a lot of the amazing care that people are providing. So I think a lot about how can technology help and not hurt? And I don't think we're there. If anybody has tried an EHR, you know.
Alyssa?
Yes, so something that I think is hugely important is humans are more complex than a single diagnosis. And up to date, many digital approaches have taken this one-size sort of standardized approach. If you have this diagnosis, you will get this protocol. And what we know is that humans are much messier than that. They're much more complex than that. They may have some symptoms that are primarily associated with depression, some that are more anxiety-related. And so we really need to understand these subtle differences between different humans' experiences and then leverage data and other sources that we have to really be able to serve up something that treats that specific person in all of their complexities as opposed to this sort of standardized one-size-fits-all approach that is frankly falling short.
So we're looking at loneliness, which is kind of ironic because we're living in an age of infinite connectedness, allegedly, and still the Surgeon General last year published a milestone report about the loneliness epidemic, quoting statistics around 50% of the population is lonely. That percentage is increasing by 3 to 5% every year from within the 18 to 80 age demographic. And the problem, obviously, is that overshadows mental health and that overshadows physical health. And I think what we've seen is a crisis, first and foremost, of activation and engagement. There are a lot of clinical resources out there, a lot of great programs, but people are either not made aware of those programs or do not feel motivated to self-care, partly because loneliness is increasing in such a rapid rate. And then the question is, what do we do about it? And I think the combination, as we'll talk more about, the combination of peer support, data, and referrals to clinical support for the right person at the right time, we believe is a breakthrough moment.
Michael.
Can you ask the question again?
Of course. Just one of the most critical perils of the current system that's top of mind for you today.
Well, there are just such a diverse group of people in this room from diverse backgrounds coming at this problem from diverse perspectives. And I think, how do we take all of that diversity and how do we sort of distill it down to its really basic principles, the North Star, sort of what are the main drivers, what are the fundamental drivers to get to the outcomes, to the targets that we all desire to obtain. And so if we can get more uniformity, more agreement, more alignment on from all the stakeholders, right, throughout the whole system, payers, policymakers, providers, if we can all just sort of get more clarity on really what is our North Star and what are those fundamental drivers to get to the end objective. How can we objectively measure, performance and value, right? And I think there's a lot of work to do there. If we could do that, then I think we have an opportunity as a community, because this is a community, to do some really impactful work together.
Thank you. Lastly.
Thanks. Appreciate the question and hearing everybody's reply. I think about this question a lot because I'm a provider and in a health plan, and I think the system is broken and is saving lives at the same time. And I feel like having a sense of humility about what is and is not working is really important. And so I love being at this conference. This is my second opportunity to be here. And there's such optimism. And when I talk with a lot of providers, there's such pessimism. My providers, my medical providers, and that's striking to me. And so I think part of what's broken is that discrepancy. And I think we can't solve for the one without thinking about the other, because everyday lives are being saved. We have a healthcare system that has, in my view, a separate medical, mental health, substance use, and autism systems, like 4 separate systems that have to align. That's part of what's broken. And so being innovative and the thinking here is so really wonderful, but there's this ground of the providers out there every day sitting with a person who's suicidal and saving their life. And that happens every day. So that's where I come from with this. So
Yeah, thank you. You all brought up really interesting points that I feel like we could all delve into. I'm kind of curious, from just the audience, raise your hand from what you've just heard. I mean, are we optimistic about striking this perfect balance? Raise your hand. Are we pessimistic? Okay, some of both. That's great. So, Boaz, I think I want to start with you. You talked about, obviously, the loneliness epidemic, which the Surgeon General in the U.S. has called a public health crisis comparable to the consequences of smoking. So when we think about using tech to really ensure that you're pairing people with the right person, with the right lived experience, and really getting outcomes when we think about social health, can you talk about what that actually looks like?
Sure. And I raised my hand about being slightly optimistic, because I think the opportunity is huge, because all of us, are walking around with this little device in our pockets, and if we can use tech with thinking about the mental health practices that can connect people to other people in the right way, and use the right assessment as those connections are being made, we can address this problem at scale, which is the only way to treat this problem, because again, we're talking about a $164 billion problem a year, to quote Vivek Murthy in his report last year. So we've taken the approach of, first and foremost, and I think your comment was very important, of identifying the right assessment. what is the baseline that we need to collect from people who are joining to begin to measure on a monthly basis whether the human-to-human connections that we provide actually move the needle in the right way. And then we have the tech working our advantage because the platform can correct itself as time goes by to connect the right person to the right person at the right time and do that repeatedly. And then if we see the measurement moving in the right direction, we know we're doing a good job. If we see PHQ numbers rise, we see GAD numbers rise, if we see UCLA, and you'll hear me mentioning these 4 letters frequently, which is the standardized measurement for alone use today in the US, we know that we're doing a good job, and we know that we should refer someone to a clinical psychiatrist or clinical therapist at the right moment, and by that solve a second problem, which is instead of by default sending the 100% of people who have mental health issues to a clinician, which is not going to work with a problem that is impacting 50% of the US population, addressing some of that with social support, and then referring the right person to the right person when they really need to speak to a clinician, and hopefully addressing the problem in a combination of peer support and clinical support.
Yeah, definitely. Greg, I want to come to you. You're a physician, you're also a clinician advocate. So kind of when you're thinking about these new models, how are you rethinking the future of care, for this need for tech transformation and innovation to change the system, but with also not losing authentic empathy, personal connection?
I wish I had an easy answer to that question. My answer for these things is always all of the above. So I think what we're trying to work on, and I have the kind of privilege in the Blue Cross space of trying to work on how do we use technology and human navigation and in-person and telehealth work, and then where do we have programs like you're talking about that are really non-clinical, and where do they fit? And that's, I think, the alchemy that we're trying to figure out. We have traditional providers, sometimes they don't want to move, they're doing what they're doing, and how do we move them at the same time that we're working with groups that are moving very fast and really pushing the envelope and sort of doing both and in between we have our members and at the health plan our accounts who have their ideas about what ought to happen, and so what we think ought to happen and what a patient of ours, a member of ours wants, I think doesn't always match, and that's actually part of what we're trying to build in these technologies, where the first vision I had of this as we were trying to do this were all these arrows that were intersecting and crossing over. I was saying, can we make a diagram of this? And it's because so we at a health plan it's like, well, it's a mild problem, it's a moderate problem, or it's this problem, it's that problem. But somebody might be coming in and wanting an in-person care or not wanting an in-person care, and then they have a clinical condition, and how do those things match, and what that member's preference is, and what our solution for them might not match. And so I think, I don't have the answer, but that's what we've kind of put in effect in the plan to try to navigate newer, easier to access groups and clinical services and pathways and navigation, and then always the ability to activate our traditional network. And so we need the easy and the hard path always at the same time.
Yeah, Alyssa, I'm curious sort of your response to that, but also, with text therapy at IESO, can you share sort of an example of how you are seeing human experts and computers obviously working together and potentially not in opposition? And I'm curious also about, the consumer buy-in for something like this.
Yeah, it's a great question. So, technology can do some things that humans can't do. It can leverage real-time insights and data to learn about the individuals that they're interacting with, and to tailor and personalize and serve up an experience that resonates for that individual. But what a robot can't do, and I'm highly confident is not going to be able to do in the immediate future, is be a human and care about the person. Think about them over the course of the week and say, hey, how's it going? Did you make any progress this week? You were going to try out this exercise. How'd that go? Did it go well for you? What can we work on? And so I think this this serving up of skills and knowledge from technology is something that we really ought to lean into to work through this scalability issue that we're facing, but then having the human being there to be a human and have connection and serve up empathy, I think is incredibly important. And so finding the right balance of how much human and how much technology, I think, is something we're all still grappling with, but I do think that that is the only viable way to work through this scalability issue that we're having in mental health care.
Yeah, Michael, what's your sort of response to that? You know, working at the Care Predictor Index, where I think your major motto is delivering actionable data insights, right, to probably, hopefully strike this right balance. So what do you sort of say to that?
Yeah, I think to some of the panelists' point, you know, the human is uniquely designed to convey this thing called love and care and compassion. And so, you know, at Care Predictor, we sort of, you know, unpack that, create a construct to really sort of understand the, you know, what are all of the elements that have to come together. It is very complex, and it doesn't always look the same in each person, but really what we want to do is sort of kind of find the pitchfork, not the pitchfork, the tuning fork, not the pitchfork. Forgive me, that was a slip. The tuning fork
That was off the record.
for optimal care, right? So, what is that? Yeah, that's the other side. So, my optimistic side is really about using technology to really ensure that harmony exists between the caregiver and the care seeker. And it doesn't just happen at one point. It is sustained over time to drive better outcomes. It is the main driver of positive outcomes, this alliance, this working alliance, this therapeutic alliance, this bedside manner. And we're starting to understand more and more that this is the main driver. Of course, the evidence-based modalities and interventions are extremely important, but absent of this love, this care, if we can't channel that force, then we're not going to get to the outcomes that we all so deeply desire.
Yeah, I love that sentiment. Switching gears a little bit, Doma, you've talked a lot about how people don't recognize how hard it is to be a parent, and the importance for family-based mental health care. The Surgeon General has also recently released something around the fact that parents are simply not okay and that there's not enough support there for parents. So I'm curious, you know, as you're building Manatee, can you talk a little bit about, you know, what you are learning about how parents want to engage with tech-enabled healthcare? What are you seeing in this kind of future of family behavioral health and the future of that?
I think first and foremost, it's really important to understand that the only thing that matters to a rich and fulfilling life is the depth and quality of your relationships. And what technology has done, it's basically diluted that, right? Like we have more connections, but they're not as deep, they're not as rich, they're not real, they're not authentic. And we see that in families too. So kind of going back to how do we design family mental health is our North Star has to be how do we deepen the relationships within the family unit? Because we all know we don't have enough providers, nor should a provider be the care system for a family. That should be the caregivers. So how do we empower the caregivers? So one of my biggest insights, truly, I got into this because I'm like, I want to help kids. And then I had a bunch of kids myself. I was like, no, I want to help parents. So ultimately, that became really the thesis and the focus of our organization. Like, how do we help parents help their kids? And it starts with kind of the technology piece that as a parent, I don't love technology. I actually don't love it. I really hate it. And for so many reasons. And so when I think about designing technology, because to the panel's point, there are things that technology can do that humans cannot do. I mean, building care for families is an operational nightmare. So that's where we lean into technology. How do we use technology to make sure that everyone's on the same page, that regardless of parent one being in Minnesota and parent B being in Colorado, that we can keep them on the same page and have the same care plan and have different assessments and these interactions that we can track. But ultimately, I really think with Manatee, we're building the scaffolding around family relationships. I don't want people to have the interactions in the app. That's why we don't really track engagement. Like, we always look at a connection score. What's a connection score? It's like, what are things that we know people are doing that are building connections, which is asking questions about each other. We have family questions that different family members answer so people can learn about each other at the dinner table. We have the ability for our kids to write journal entries that they can then share with their parent. And 33% of kids do that, which is wild. Nobody thought that teenagers would actually share their journal entries with their parents, and they do. So anyway, very long-winded way of saying, I think for us, technology really functions like, how do you build the scaffolding so that families can deepen their relationships in real life and not in an app?
And you've said before too that you don't want Manatee to feel like treatment, and I think that's really was interesting to me, because one of the biggest problems in healthcare is a lack of engagement, and meeting people where they're at and thinking more so about prevention in this word that or phrase that we talk a lot more about around mental fitness versus just mental health care treatment. So I'm curious, when we think about engagement, and really keeping people coming back, does anyone else want to kind of jump in on making it not feel like treatment?
Yeah, I think, looking at how treatment has been, the clinical setting, sort of insipid, right? Needs to be more inspirational. If you look at, kind of the vast majority of the people that we support, what percentage are high acuity, what are sort of that mid-range, lower range, and the provider in that instance, when they're mid to lower range, has less effect on the outcome on their own. A lot of it actually is, right, in the internal motivation of the person that we're supporting. And so what drives that change is action on behalf of that person we're supporting. Well, then what is the main driver of supporting that action that the person will take on their own? That is, if they're inspired and supported, right? If they're in a relationship with somebody who can inspire them to take their own action on their own behalf. So we have, if we had a higher acuity population, such as a open heart surgeon, we put them on the surgery table, we put them under anesthesia, we perform the procedure, the outcome, we have more control in that scenario. But because we're not dealing with that type of population, we have less control. So we have to be really good at being inspirational, at being supportive, at being connected, right? That's the main driver.
Just one thought in this context. What we found is that the human need to connect to someone who's been in your shoes is something that is not going away. And then the question is, what's the role of technology in that context? Well, the role of technology is to help you connect to someone who's been in your shoes, who may not be living in your vicinity, or you don't have access to those specific networks, which goes to the best definition of loneliness that I've read in the Surgeon General's report, which is essentially a gap between the social support networks that you have in your life and the ones that you would like to have. What the other piece of good news is that social health is a science. So when we talk about connecting to people, it's not just connecting them and hoping that the assessment is going to improve. There are 4 pillars of social health, as identified by Professor Dan Russell, who co-developed the UCLA scale. I told you I'm going to say UCLA a number of times. One is emotional support, connecting you to someone that you feel cares about you. The second is a sense of belonging, connecting you to someone who you feel there's a shared experience between you two. The third is what he calls reliable alliance, giving you the opportunity to help others. And the fourth is a sense of worth, helping you feel as if the things that you're going through are things that can translate to insights that you can offer to other people. And if you can work those 4 pillars of social health into the connections that you help make using technology, you can improve mental health at scale, which is what we're trying to do.
Yeah, definitely. I wanted to bring up, something really important. Just last month, the mother of a 14-year-old boy who tragically died by suicide sued an AI companion company, saying she believed, it was linked to his relationship with an AI chatbot companion. And I bring this up because, as we think about digital innovation, it's really important that we have the proper guardrails. And whether or not you're specifically in that industry or not, what was your reaction to that? And what does it influence the way you're thinking about things moving forward? Anyone can jump in.
I mean, when I think about Manatee, we don't introduce AI at all on the care, like providing care and interfacing with kids and young people. Because one, the models aren't there yet for young people at all, not even a little bit. And two, there is, like, when you think about the development of the brain, there's a very big distinction between a grown, developed brain who can understand the distinction between those things and a 14-year-old that still has a ton of neuroplasticity. It's just a recipe for disaster. So I guess my thing is, like, AI should not deliver any type of care to young people.
Okay. Alyssa?
It's obviously absolutely devastating. I'm also a parent. I cannot imagine what that mother must be experiencing. And so I think it really highlights the importance of responsible innovation. We have to be relentless in our testing of safety, evaluation. We need to incorporate people with lived experience, involve them in the testing, evaluating of programs. We need to be transparent about how we're training models, who trained the models, what data they're based on, and we all have to do this collectively. That is the only way we will ever be successful, is if we all sort of lock arms around this, that we are going to be transparent, we are going to take these specific steps to be ethical, we're going to take these steps to validate, to evidence, and move forward together. I do believe that AI is going to play an important role in the future in the delivery of mental health care, and we have to be so thoughtful and so discerning and so careful about how we build those programs and test them and make sure that they're safe.
Thank you. Really well said. And Greg, before I sort of go into audience questions, is there anything that you don't think we're talking enough about from your perspective when we think about striking this perfect, maybe that's more an optimal word, but balance?
No, it's been great listening to everybody, because I think this tragedy of a suicide causes people to want to point blame anyway. So it's easy to point to the AI. But it's a very concerning technology for providers. And I think providers, as we think about technology, I think aligning the incentives and the technologies with, payers, providers, patients, employers, I think is really going to be important. And having that transparency among these systems that all are seeing a different part of the elephant and have a different point of view of what's the most important thing. So if you talk to the average physician, technology has been the bane of their existence. And so I'm at a technology company for mental health, and if I talk to my physician, there's like Epic. If you say the word Epic to a physician and see what they do, they will go bananas. So, it has been so intrusive on the practice of medicine. And so we're trying to fix the system that's broken, that the physicians think are broken too. I'm speaking for physicians as a physician, but it's mental health practitioners of all stripes. But it's a really important thing. So as that humility, as we do innovative, wonderful, optimistic things here, I always want to kind of try to tie back to that, because every doc I know, every good doc wants to do the right thing and spend time. And so technology that facilitates that and connects, I have patients in my practice, they do an app or they do a thing. I'm like, well, can I get a report or some readout, or what are you doing? If it's disconnected, it's really hard. It doesn't serve the treatment that they're already in, right? So, we need to do things because things are not happening, but people are in treatment. And so being able to sort of do both, and some of these technologies, they have to then live in the healthcare ecosystem of HIPAA and all of those all of those regulations and things there. So I think I love the work that everybody's doing here, and I would just encourage everybody to remember that there's a lot of people just struggling in the trenches every day, and technology's getting in their way.
Is there, just a quick follow-up, is there sort of a sense of, when you say you work with clinicians, that that they're really looking for in terms of how they want their care to look for, their job, because I think we're talking a lot about the consumer of these tools. I'm curious, when it comes to these physicians, is there any misconceptions that you kind of could debunk for the room around what it might be that physicians are looking for?
I think there's, I think they want technologies that make their job easier and better. They want to be a physician, which is about the doctor-patient relationship. I mean, that's what the Hippocratic Oath is about. It's really about doing no harm to a human being. It's a very profound oath to say. And when technology, administrative burden, all this stuff gets in the way. So the things that you do here in technology are going to be perceived as getting in the way more often than not, unless they really don't. So I always went into this is going to save you time, it's going to save you money, and it's like, it's going to cost me time and it's going to cost me money, so why do I want it? And so if any company that would get into a true dialogue with, as a practice owner for many years, that's what I would say. And so I think something that really makes the practice of medicine more rewarding and takes away some of that administrative burden is part of what they want. I'm meeting with a lot of companies that are actually doing that and figuring out how to add things that we want as a payer. Do measurement-informed care. Not all physicians, not all mental health people believe in it yet. So you're ahead of them. Know that you're ahead of them. I, as a psychiatrist, as an APA and AMA member, are trying to get docs to want to do that, but they're like, what are you doing for me, is what they think. So, so a lot of companies are sort of working on that. And I think that if you make their lives more rewarding with their patients, that's what they want, and kind of get out of the way. And we're trying to do this plan too.
Yeah, I just wanted to add to that. Like, I want to be clear. I think AI can play a massive role in making the lives easier and better for our providers. If I think about, our team of providers, and if you ask them, like, what are the things you really don't love about your job? I mean, administration, note-taking, scheduling, right? Like, all of those things, 100%. Let technology solve that. Billing, I mean, all the things. But then I do think truly, like, the relationship specifically within mental health, specifically with kids and families, is like, we talked about this at breakfast, it's sacred. You cannot replace that with technology. And I think that's so important to remember, that when we think about skill and we think about access, I always go back to every family needs support. Not every family needs a clinical licensed psychologist, right? Like, there's 100 things that you can do before that, where I think, kind of like connection, peer support, digital tools can play a role. But really, truly, if I look at our clinical team, like, what are the things that they hate doing? Solve that. The one-on-one relationship with their clients, that should be the provider and a human.
If I can future forecast a little bit here. So ASO has a study under review where we found that we had comparable outcomes via this sort of digitally delivered mental health program with some human clinician time. It was about 1/6 of the time that a human clinician would typically spend with their patients. And so in future forecasting a bit, I think that there's still absolutely a role for clinicians. They are undoubtedly important. I am a clinician myself, but I think the role of the clinician may shift. I think the way they spend their time may look a bit different. When you're providing most evidence-based therapies, it's very skill-based and very conceptual-based. I'd have days where I'd have 6 sessions back-to-back where I was teaching the same skill for each person. So we can let the digital do that heavy lifting, teach the skill, teach the concept, and then you have a clinician able to be freed up to tailor to that specific person, their specific use cases, their sleep schedule, if they do shift work and they can't practice at the normal time, or whatever it might be, but really help tailor these interventions and do so on a much wider scale than they're presently able to do. So I do think that, it may be slightly scandalous, but I do think that clinicians still will absolutely have a role, but I think it's going to evolve in the future and look a bit different.
Amazing. There was no questions in the chat here, but did anyone from the audience want to ask a question? There's some, go ahead. I think, if you wanted to just step up here. Feel free to introduce yourself as well.
Hi. Thank you. My name is Zaid Bajwa. First of all, Can you hear me?
Yes.
Yeah. Thank you for the great presentation. So, as somebody with a lived experience, so the question I have is, we talk about AI. So, how do I trust? So, nobody has my data. So, my provider is on a different EMR, my therapist is on a different EMR, and as we change, my primary care talks a different language. So, I don't know for a fact, nobody can build a model right now that's going to be accurate on me as a patient. So we have these buzzwords, we talk about AI. I think I don't have confidence right now to speak because having been to 18 providers in the US and my data, nobody shares data. Average American changes their payer every 2 years. Payers are the biggest hostage of data. Blue Cross Blue Shield, there's no sharing unless somebody authorizes it. So I don't know, when we talk about these things, data models, so there's a concept called garbage in, garbage out. So as of right now, I don't think so. We talk about these things. So you have Epics, you have Cerner, you have NetSmart, you have Athena Health, you have GE, you have McKesson, you name it. And everybody has free choice of what they use. So how do I trust or how do I know that models that are built right now are accurate? They will be accurate in the future.
Yeah.
Because
Thank
there
you.
is no such guardrails around them.
Yeah,
Go
so
ahead.
I can speak for IESO specifically. IESO's data set and models are trained off of 750,000 hours of provided therapy. So we have the full transcript from the therapist as well as the patient indexed with weekly outcomes. Now, is it going to be perfect for every individual and nuance? Absolutely not. But at that scale, you start to see patterns and can discern, okay, this specific action is more likely to be effective for this person with this symptom profile. But you're right, it's impossible to have every use case and every utterance, but you have to at some point play the odds a little bit of like, okay, for most people who are experiencing this thing, this intervention can be helpful, and then continuing to fine tune and harness those models. And I'll also say, the comparison is to a human, and there are many human clinicians who lack experience with a certain, specific profile, et cetera. So I don't think that the alternative is necessarily superior. It can be, but I think that's something we have to keep in mind too. There's a lot of education that providers go through about like cultural differences, et cetera, but we still have a long way to go towards health equity, social determinants of health, all of those factors. And so it's not a perfect solution, but I also would argue that human care is also not a perfect solution.
The session about AI was, in the largest auditorium in this conference, and I think that says something. And also the kind of the atmosphere around the room when we start talking about AI. AI is going to play a role in all of our lives, in a fairly prominent role in all of our lives, and it will play a prominent role in healthcare as well. I think the question is how to deploy that tool to make sure that you're helping people and helping more people move towards health. To your question, I think the point that you're making is right. The AI is going to be as good as the data that is fed into the AI. So the question is, for example, what are the self-reported questions that we want to put in front of people joining a platform like Wisdo so we can implement that data in models that would help us make better connections between people. And I think there's a slight misconception about AI, thinking whether it's either human connection or it's AI. There is a third option, which is what some of us are doing, which is we like to call it a co-pilot, which is deploying AI as a tool that can suggest to people what they should say to specific people based on millions of prior interactions to help them have a more meaningful and more healthy conversation that is more probable to move people in the right direction. So you're not replacing the humans, you're actually building on self-reported data that was submitted by humans in interactions with other humans, and then using that data to recommend things that can help humans do a better job.
Great. Thank you for that. We're coming up a little bit on time, and so I want to and hopefully a bit optimistically, I started by asking each of you sort of one of the biggest problems that you're seeing in the system that you're focused on. So Michael, why don't I start with you, and then we'll hit everyone kind of within, as briefly as you can. What is the single most exciting innovation within this space right now, the behavioral health tech space, that you're looking at today?
Well, I'm biased, of course. So the ability to use technology and data to really quantify and amplify empathy.
Amazing. Great and concise, Greg.
I think aligning different groups and aligning incentives, I've been really excited with the use of technology to begin to do that and bring people together. And I see a lot of that in this conference.
Awesome. Doma, do you want to go?
Oh, I've been thinking so hard. I do think like my favorite thing where we are right now is just the introduction of really helpful technology. I love that we can be much smarter around like Sky. I know that I'm contradicting, but really like what's the admin burden that providers have and providing that insight also, to your point, like AI can be like a really amazing co-pilot. My other thing that was a cop-out answer was I think my favorite thing is that everybody's talking about mental health. Like this conference did not exist 2 years ago. And for me, I think that's the most exciting part. When I look at our younger generations, the way that they talk about mental health and connection, the awareness, it's so different. I think most of the people in this room, like we didn't have that growing up. You were just like, what are you talking about? So it's not a technology innovation, but I think that's really exciting.
No, and I love that answer. That works. Alyssa, and then Boaz.
Yeah, mine is definitely related to that in that, so I started my career as a professor. I was training future therapists, seeing my own caseload, and I was so frustrated by this disconnect between the reality that most people in the United States who need mental health care receive nothing, and when they do receive something, it's rarely consistent with evidence-based practices. And so to me, the idea that we are able to reach this many people, and it's a scale beyond my wildest dreams, what I ever thought possible early in my career, and the fact that we have all these people together talking about like, how do we do this? How do we change our policies? How do we set up our community? What can we do beforehand? And have this whole spectrum of thinking about where we can intervene, how we can shape things to reach people on a scale that was just never even conceivable before is incredibly exciting.
Yeah. Boaz, you
Here,
have the
here.
last word.
I'll add another thought. A few years ago, we still had to explain what loneliness is and why this is an issue. That is no longer the case. We start, conversations with potential clients and partners and, people in the space, and we start talking about loneliness, and they say, skip. We understand the problem. Skip to the solution. So that's a really good thing because social health overshadows mental and physical health in a very big way. And that is echoed by decisions made by federal and state agencies that I think are going to impact social health in a very big way. CPT codes, Z codes, all that world of reimbursement is going to change how we think about social health. I think when we look to the future, I think it is reasonable to expect that people will be invited to go through social health screening on a regular basis. Much like you have your physical and your annual checkup, there's going to be a series of UCLA questions that you will answer to make sure that your social support networks are as strong as they should be. And if you fall beneath the required UCLA spectrum, then you would be recommended to take a look at a bunch of solutions that will be reimbursed by the industry. So, and of course, when that happens, I think we are granted a real opportunity to impact social health at scale.
Yeah. Well, thank you all for that. Leaves us on sort of a positive note and sort of striking the right balance. And I really appreciate all of you. And I'm sure if anyone else wants to ask them or grab them after this, I'm sure they'll be willing to chat. But thank you all so much. And yeah, enjoy the rest of the day.